imagine for a second that you were a medical detective.
Okay, I like where this is going.
Right. So a patient carefully shuffles into your clinic. They have this progressive, creeping inability to feel the ground beneath their feet.
Which is terrifying.
Totally.
Yeah.
It started as just a faint numbness, but now it's a profound unsteadiness. Maybe it's accompanied by a tremor in their hands. So you run the standard tests for peripheral neuropathy. Diabetes, clean.
Right.
Vitamin B12 deficiencies, clean.
Yeah.
Toxins, alcohol abuse, metabolic panels, everything comes back completely normal. The obvious culprits have totally skipped town.
Yeah, you're at a diagnostic dead end.
Exactly. So where do you look next? Well, you have to look deep inside the bloodstream. You're looking for a microscopic clone army.
Yeah, because when the structural integrity of the peripheral nervous system is under attack like that, and you've ruled out all the standard metabolic causes, you really have to consider that the body's own immune system has spawned a rogue element. We're looking for an abnormal clonal proliferation of plasma cells or B cells.
Which brings us to our topic. Welcome to today's deep dive. We are unpacking a fascinating and honestly incredibly complex medical landscape.
It really is.
We're basing this on a highly specialized article by Dr. Saidar Badian and Dr. Layla Darkey on paraproteinemic neuropathies. No, it's a mouthful.
It is, but the underlying biology is like a biological true crime story.
Exactly. Our mission today is to explore this bizarre intersection where rogue blood proteins attack the peripheral nerves. We'll dig into how doctors actually crack these notoriously difficult cases and, look at the brutal biological trade-offs involved in treating them.
And understanding these disorders is just crucial because it requires bridging two medical worlds that usually operate in complete silos.
Neurology and hematology, right?
Exactly. If a clinician only looks at the nerve damage and ignores the blood disorder, or vice versa, treats the blood disorder without considering the nerves, the diagnosis is missed entirely.
Or the patient suffers irreversible damage.
Yeah, exactly.
So let's start with the weapon being used here, the paraprotein. We know that in conditions like monoclonal gammopathy of undetermined significance, or MGUS,
Right, MGUS.
a single rogue plasma clone starts multiplying. It basically turns into a rogue factory, pumping out an excessive amount of one identical, totally useless immunoglobulin.
The heavy chains like IgG, IgA, IgM, and light chains.
Right, the blood just gets flooded with this paraprotein. But I'm struggling to understand the clinical logic here.
How so?
Well, both standard wear and tear peripheral neuropathy and MGUS are incredibly common as people age.
They are very common.
Right, so if a 70-year-old patient with, say, borderline diabetes comes in with numb feet, and the blood test shows they have these rogue proteins, how is a neurologist supposed to know if it's a causal link or just a total coincidence?
That right there, that is the coincidence conundrum. It is the single biggest trap in this entire field.
Really?
Oh, absolutely. Just because polyneuropathy and a monoclonal gammopathy coexist in a patient does not mean the paraprotein is the thing actually damaging the nerve.
So they could just be unrelated issues happening at the same time.
Exactly. So to separate coincidence from causation, you have to use rigorous clinical and electrophysiologic phenotyping.
Okay, what does that look like?
Well, first, your standard serum protein electrophoresis, the usual test. It often misses the paraprotein entirely if the clone is small.
Oh, wow.
Yeah, so doctors have to order a serum immunofixation test. It's much more sensitive.
Okay.
And they also have to run a urine test to check for isolated light chains, which are known as Bence-Jones proteins.
Okay, so let's say you do that. You find the protein. How do you prove it's the actual culprit causing the nerve damage and not just, an innocent bystander?
You look for red flags.
Like what?
If the neuropathy is rapidly progressing, or if the patient is fainting from sudden drops in blood pressure.
Oh, because that indicates autonomic nervous system failure.
Precisely. Or if the nerve conduction studies show very specific uniform patterns of demyelination, but the biggest clue, the subtype of the paraprotein itself.
Okay, break that down for me.
If the patient has an IgG or IgA paraprotein and a standard demyelinating neuropathy, the literature shows it is very often just a coincidence.
Okay, so IgG and IgA are usually innocent bystanders.
Often, yes. But if the lab comes back showing an IgM subtype, the statistical likelihood of a direct causal attack on the nerves just skyrockets.
And the text actually highlights that 50 to 75% of paraproteinemic neuropathies occur with that specific IgM paraprotein.
It's the primary suspect.
So let's look at how this specific protein operates, because the mechanism here is wild. This usually manifests as anti-MAG neuropathy, right?
Yes. So MAG stands for myelin-associated glycoprotein. It is a vital transmembrane protein located in the outermost layers of the myelin sheath.
The insulation wrapped around your nerve axon.
Exactly. And in anti-MAG neuropathy, those rogue IgM antibodies in the blood are specifically targeted to bind to that exact MAG protein.
So they're circulating through the blood, they find the peripheral nerves, and they literally physically latch onto the insulation.
They do.
What actually happens to the nerve once they attach?
The source material includes this incredible electron micrograph that visualizes this perfectly.
Yeah, saw that.
Under normal conditions, myelin is tightly compacted around the nerve fiber, kind of like layers of electrical tape.
Right.
But when these massive IgM antibodies bind to the MAG protein, they physically wedge themselves between those myelin layers. They force the lamellae apart. Pathologists actually call this widely spaced myelin.
So it's literally peeling the nerve's insulation apart from the inside out.
That is exactly what it's doing.
I mean, I'm assuming that completely wrecks the nerve's ability to conduct electricity.
It does. It alters the capacitance of the nerve fiber. The electrical signal is supposed to jump rapidly down the nerve, but when the myelin is widely spaced like that, the signal leaks and slows down dramatically.
Which you can measure, right?
Yeah, on a nerve conduction study, you see severely prolonged distal motor latencies. The signal just crawls when it reaches the extremities. And clinically, this predominantly hits the large sensory fibers first. Those are the nerves responsible for proprioception, telling your brain where your limbs are in space.
Which completely explains why these patients don't usually present with a ton of muscle weakness right away.
Right.
Instead, they have sensory ataxia.
Yeah.
Like a wobbly, uncoordinated gait. They have a positive Romberg sign, meaning they close their eyes and immediately lose their balance.
Because their brain literally cannot feel where their feet are.
That's terrifying.
Oh.
And they also frequently develop hand tremors.
We see this really clearly in case 9-1 from the text.
Oh, yeah. This 73-year-old man.
Right. He had 3 years of worsening sensory symptoms and an unsteady gait, especially at night when visual cues are reduced.
Because he couldn't see the ground to compensate for the lack of feeling.
Exactly. His doctors found an IgM kappa monoclonal gammopathy, but they initially misdiagnosed his nerve issue as CIDP.
Which is chronic inflammatory demyelinating polyradicular neuropathy. A completely different demyelinating disease.
Yeah, so they treated him with IV intravenous immunoglobulin.
And he felt a little better initially, right? But the treatment ultimately failed, and the nerve damage just kept progressing. So why is that misdiagnosis so common, and why didn't the IV work?
Well, CIDP and anti-MAG neuropathy look really similar on basic electrodiagnostic tests because both feature demyelination.
Okay.
But IVAG works for CIDP by flooding the body with healthy donor antibodies that modulate the general immune response.
Right, it calms the whole system down.
But in anti-MAG, you have a relentless factory, that specific B-cell clone just pumping out targeted IgM weapons. General immune modulation doesn't shut down the factory.
I see.
To stop anti-MAG, you have to use a therapy like rituximab, which specifically binds to the CD20 antigen on B cells and depletes them.
Okay, but even then, the stats are incredibly sobering. The sources note that rituximab only leads to clinical improvement in 30 to 50% of patients.
It's definitely not a guaranteed fix.
That's rough.
And that is exactly why catching this early is critical. Neurologists have to catch this early. If the demyelination goes on too long, the axon itself, the underlying copper wire of the nerve, starts to suffer from the lack of support.
It just goes up.
It undergoes secondary axonal degeneration. Once the axon dies, the nerve fiber is gone permanently.
So even if you stop the attack, the damage is done.
Right. You could completely eradicate the B-cell clone with rituximab, but if the axon is already dead, the patient will never regain feeling in their feet. No amount of immune therapy will bring it back.
Okay, so anti-MAG is this highly targeted, localized attack on the myelin sheath. But the deep dive explores rare variants where the rogue proteins don't just attack the nerves, they trigger massive, system-wide biological disasters.
They could do.
Let's look at AL amyloidosis. How does a paraprotein cause that?
So in AL amyloidosis, the culprit is usually a lambda light chain. But rather than acting like an antibody seeking a specific target like MAG, these light chains are physically unstable.
Unstable how?
They misfold into beta-pleated sheets. And because of this misfolded sheets, they become highly insoluble. They aggregate and deposit into tissues all over the body as a substance called amyloid.
Wait, so if I'm picturing this right, instead of a targeted attack on the insulation, These misfolded light chains are basically acting like wet concrete getting poured into the body's plumbing and just hardening wherever they settle.
That is exactly how it functions. And in the nervous system, this concrete tends to deposit around a small diameter sensory fibers and the autonomic nerve fibers.
Okay.
This creates a completely different clinical picture than anti-MAG. Instead of a wobbly gait, these patients present with agonizing, burning nerve pain.
Because the small fibers handle pain and temperature.
Exactly. They also develop severe dysautonomia.
Right, because the autonomic nerves control the automatic functions of the body. So they have profound orthostatic hypotension like passing out when they stand up, along with severe gastrointestinal issues.
And the concrete is pouring into the organs too, leading to massive heart failure.
How do you even confirm that's what's happening? Blood tests can't see the concrete, right?
No, they can't. You have to biopsy the tissue. Typically, doctors take an aspirate of abdominal fat or perform a sural nerve biopsy.
Ouch.
Yeah. Then they treat the sample with a specific dye called Congo red. Because of the unique beta-pleated sheet structure of the amyloid, the dye slides right between the folds.
Oh, wow.
And when you view it under a polarized light microscope, it glows with this brilliant, highly specific apple green birefringence.
Apple green birefringence. It's an almost eerily beautiful visual for something so totally destructive.
It really is.
Now contrast that wet concrete mechanism with Poems syndrome, which stands for polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes.
Quite an acronym.
Seriously, what's happening in Poems?
Well, POEMS is a paraneoplastic multi-organ disorder. It's usually driven by an osteosclerotic myeloma, which is a bone-hardening plasma cell tumor. The paraprotein is typically IgA or IgG lambda. But here's the thing. The nerve damage isn't caused by the protein directly attacking the nerve or depositing as amyloid.
Then what's doing the damage?
The plasma cell disorder triggers a massive overproduction of inflammatory cytokines, most notably vascular endothelial growth factor, or VEGF.
Okay, let me build on the analogy here. If anti-MAG is a targeted sabotage of the electrical insulation, and AL amyloidosis is wet concrete clogging the pipes, POMS sounds like someone pulled the master fire alarm in a high-rise. The VEGF floods the entire system, causing the sprinklers to go off on every floor and sending the whole building into chaos.
That is a highly accurate way to look at VEGF.
Really?
Yeah. Vascular endothelial growth factor's primary job is to promote angiogenesis, the growth of new blood vessels, and to make existing blood vessels permeable.
So they leak.
Exactly.
Yeah.
When VEGF levels skyrocket, your blood vessels become incredibly leaky. Fluid just leaks into the tissues everywhere.
Which explains the symptoms.
Right. This causes the organomegaly, the swollen liver and spleen, and the profound skin changes. And in the peripheral nerves, this extreme vascular permeability causes severe endoneurial edema.
Edema meaning swelling.
Yes. The nerves are essentially crushed by the swelling and inflammation within their own protective sheaths.
Oh, that sounds awful. And clinically, that sets it apart from CIDP immediately, right? Because the polyneuropathy in POEMS is acutely painful, and it features significant muscle weakness and atrophy right out of the gate.
Whereas anti-MAG was mostly sensory ataxia.
Exactly. Just to cover one more rare manifestation, the text brings up Canomad. Chronic ataxic neuropathy, ophthalmoplegia, IgM paraprotein, cold agglutinins, and disulfonyl antibodies. I mean, we have another alphabet soup here, but why does this one cause such a bizarre presentation?
Canamat is fascinating because of its extreme specificity. The rogue IgM paraprotein here contains disulfonyl antibodies.
Okay.
And these antibodies specifically target gangliosides like GQ1B and GD1B.
Which are found where?
Well, these specific gangliosides happen to be heavily enriched in the cranial nerves, specifically the ocular motor nerves that move the eyes and the bulbar nerves that control the throat.
Wow.
So while anti-MAG hits the long nerves in the legs, Canomad literally paralyzes a patient's eye muscles and destroys their ability to swallow or speak.
That's terrifying. These rare variants, amyloidosis, POEMS, Canomad, they really drive home the reality that the peripheral neuropathy isn't a single disease.
No, not at all.
It's just the tip of the iceberg. It's a blaring alarm for a massive hematologic crisis.
Absolutely. A neurologist looking at a patient with apple green birefringence or sky-high VEGF levels, they cannot solve this alone. They have to immediately sound the alarm for an oncologist or hematologist.
You cannot treat the nerve without treating the underlying bone marrow or blood cancer.
Exactly.
Which brings us to the most difficult reality of this entire topic, the treatment paradox.
It's a tough one.
Because once you identify that the numb feet are being caused by, say, Waldenstrom macroglobulinemia or multiple myeloma, the only way to save the patient is to aggressively attack the cancer.
You have to eradicate the clone cells making the paraprotein, and hematologists bring in powerful therapies for this: stem cell transplants, radiation, and advanced targeted agents like Bruton tyrosine kinase inhibitors.
But the irony here is just brutal. The very drugs used to save a patient's life from multiple myeloma are profoundly neurotoxic.
They are.
The source text explicitly highlights that treatments like thalidomide and bortezomib actually cause sensory predominant peripheral neuropathies in 30 to 50% of patients.
It's a staggering number.
You are literally trying to cure a neuropathy-inducing cancer by using a drug that causes neuropathy.
It is an agonizing clinical tightrope. Bortezomib, for example, is a proteasome inhibitor.
How does that work?
It works by stopping cancer cells from clearing out their waste proteins, which causes them to die.
Okay, sounds good for killing cancer.
It is. But the dorsal root ganglia, the clusters of sensory nerve cell bodies right outside the spinal cord, they lack a protective blood nerve barrier.
Oh, no.
Yeah. The bortezomib gets in, stops the sensory nerves from clearing their own proteins, and the nerves become severely damaged.
So how does a medical team possibly balance that? You have a patient whose bones are literally being eaten by myeloma, but the drug you are pumping into their veins is going to permanently destroy their ability to feel their hands and feet, leaving them in chronic agony.
And this is exactly why the multidisciplinary clinic is non-negotiable. The hematologist and neurologist must monitor the patient constantly. They're constantly weighing risks and benefits.
Right.
If a patient on bortezomib starts developing severe neuropathic pain, the team often has to pivot mid-treatment.
To what?
They might switch the patient to a second-generation proteasome inhibitor like carfilzomib. Carfilzomib is structurally different. It's an epoxy ketone, and it has less off-target effect on the nerves,
So it lowers the risk.
significantly lowering the risk of severe neurotoxicity while still fighting the myeloma.
All while managing the daily reality of the patient's pain. I mean, they have to use symptomatic treatments, SNRIs, gabapentinoids, sodium channel blockers, just to quiet the chaotic misfiring of the dying nerves.
Alongside physical therapy and orthotics to keep the patient mobile.
It is a constant battle to achieve cancer remission without completely sacrificing the patient's quality of life.
Curing the myeloma is a Pyrrhic victory if the patient is left permanently disabled and intractable pain. The key takeaway here is that treating the patient requires constant, vigilant monitoring of their peripheral nerves.
Let's step back and look at the territory we've covered today. We started with the patient shuffling in with numb feet and learned how to hunt down a microscopic clone army making identical paraproteins in the blood.
We did.
We explored the coincidence conundrum separating normal aging from the targeted attacks of the IgM paraprotein. We saw how it physically wedges apart the nerve's myelin insulation.
Widely spaced myelin.
All right, and we navigated the complex multi-organ chaos of amyloidosis acting like wet concrete and the massive VGF inflammatory storms of Poem syndrome.
It's a lot to take in.
It is. And finally, we looked at the incredibly difficult clinical paradox of treating a blood cancer without destroying the very nerves you were trying to save. Ultimately, we learned that saving the nerves requires a delicate multidisciplinary dance between neurology and hematology.
It is a stark reminder of the body's deep interconnectedness.
Absolutely. Now, before we wrap up, there is one final mind-expanding idea pulled right from the bleeding edge of the research mentioned in the source material.
Oh, this is fascinating.
We spent a lot of time talking about how current treatments rely on B-cell depletion like rituximab or blunt force chemotherapy to wipe out the immune cells making the rogue antibodies. But it carries all those toxic side effects.
Right, you are carpet bombing the factory to stop the weapon.
Exactly. But researchers are currently studying a completely different approach in animal models right now. Antigen-specific glycopolymers.
Decoys.
Yes. Imagine a future where, instead of using toxic chemotherapy, doctors inject microscopic synthetic chemical decoys into your bloodstream. These polymers are designed to perfectly mimic the MAG protein, the myelin insulation of your nerves. The rogue anti-MAG antibodies circulating in your blood are completely fooled.
They bind to the decoys.
They bind to these synthetic decoys instead of your actual nerves. The decoy antibody complex is then naturally and harmlessly flushed out of your system by your liver.
It's brilliant. You leave the patient's immune system intact, you avoid the neurotoxic chemotherapy entirely, and you simply intercept the weapon before it ever reaches the nerve.
A microscopic game of chemical deception to save the nervous system. Definitely something for you to chew on long after this deep dive ends. Thank you for joining us as we explored this material. Remember, no matter how standard the symptoms might look on the surface, sometimes the real culprit is a rogue clone hiding in the bloodstream.
It forces us to rethink everything we know about how the body breaks down.
Stay curious.